We'll talk about the aesthetic criteria, or the things that we need for the criteria, the parameters that we need. And the first thing that we have to do when we're talking about the aesthetics is that we have to choose an implant system that is going to allow a proper biological result to both our hard and soft tissues. We have to choose an implant system that is going to give us stability or maintain the soft tissue or improve the soft tissue over a long period of time, not only the mesial distal direction, but also the facial cervical area. And of course, when we're talking about aesthetics, we want to make sure that the tooth that we're going to be replacing is going to be equal to that in volume of the contralateral tooth or whatever other tooth is nearby in order for us to get the aesthetic result. David asked me to speak about the tissue stability in the form of both aspects of both color stability as well as the shape of the stability of the tissue. So that's what I'm going to be speaking on. Now, we hear the terms bandied about shape, color, and contour when it comes to aesthetics. But what is that referring to? Well, the tooth that we're trying to replace has a shape, color, and contour, as well as the soft tissue that we're trying to replace, which has also got its own shape, color, and contour. And the one thing that is in between that tooth and the soft tissue is what? It's the abutment. And the abutments have their own shape, color, and contour. And we're very lucky that we're dealing with an implant system that, because of the unique connection that it has, is going to allow bone to have apposition on top of the platform, which is going to be a scaffold for the soft tissue that follows. And Dr. Piatelli is going to be talking about that later on. But now we have our abutment, our intermediary abutment, and you're going to see that the intermediary abutment is going to have a special relationship with that of the tooth that we're going to be able to see when we look at the tooth straight on. And that abutment is also going to have a special effect with the soft tissue. That'll become very apparent when we take a look at the tooth from the side or from the sagittal view when we talk about the contours of that. And we also have to remember that this is not just occurring in 2 dimensions. We've been speaking about 3 dimensions the past day with Scott and Marcus and others, and this is also taking effect in 3 dimensions. This is effect that the bone and the soft tissue stability is rotating around 360 degrees. So the question that we have to ask, 2 questions that we have to ask: are the abutments the determining factor for success? And what do we need in abutments for the maximum amount of success? Well, when all is said and done and we're ready to begin our restorations on the ankylosed system, this is a type of tissue that we're looking at. And it's a little bit different from other type of implant systems because you notice one thing: there is no prosthetic platform. The fact that there is no prosthetic platform is going to offer us 2 huge advantages. Number one, we're going to see a maximization of the soft tissue. And the other advantage that we're going to have is this, that we're going to have the emergence profile of the crown, which is going to be independent of the implant size. Because when we're dealing with any other system that has a platform, we are now letting that platform dictate everything for us. As a matter of fact, when we're dealing with implant systems that are dependent on a platform, we're really going against one of the basic tenets of implant dentistry about preserving the bone and the soft tissue, because in this particular situation, we now have to remove the bone and soft tissue to expose a platform. For what purposes? Only for the restorative aspects. So now that we have this maximization of the soft tissue, we have 2 other questions that we have to ask. Is this going to have a thicker tissue? This thicker tissue, is this going to have an advantage? And how is this going to affect the abutment choice? Well, I have a very simple formula that I follow. A plus C equals T. A being the abutment, and we have a variety of abutments from which we can choose. C being the crown, and we have a variety of crown materials from which we can choose, equals T, which is the shape of the soft tissue. And it's not like there are any numbers that we're plugging in. We're not trying to quantify anything. As a matter of fact, when we talk about T, the shape of the tissue, there is only one answer. The shape of the tissue has got to be perfect. It's only how we're going to look about it in proportions between how we're going to be shaping that tissue between the abutment and the crown to get to that perfect situation. That's all we're trying to do. And we know that the shape of the tissue is going to be different in different areas of the mouth. For instance, in the anterior area of the mouth, we're going to have more of the triangular shape. So we're either going to be forming that tissue with a little bit of the crown and more of the abutment, or maybe a little bit more of the crown and less of the abutment. In the posterior region, it's going to be the same. We're going to have a little bit of the abutment and more of the crown for shaping the soft tissue, or possibly more of the abutment and less of the crown. Remember, it has to equal the tissue. It's just the amount of proportion that we're going to be dealing with it. So I'm going to now get to the topic that David asked me about, the shape and the color of the tissue. And I'm first going to start off talking about the shaping of the tissue. Because when we talk about the shaping of the tissue, we have a variety of ways in which we can accomplish that. And they're all correct. We can shape the tissue with the abutment. We could shape the tissue with the crown, we can shape the tissue with a combination of both, or we can shape the tissue by other means, such as with provisional restorations or customized sulcus formers, as Renzo's working on right now for the ankylosing system. But the shape that I want you to think of is the shape of the brandy snifter. Not because a brandy snifter is anything that I'm using a lot. That's, for those of you who know me, you know that brandy is not my drink of choice, but it's a unique shape. Because the shape of the brandy snifter is basically the shape that Paul Weigel has been harping upon us for the last couple of years. Like with the ankylosing system, you have a little skinny stem coming out, and then we want to have an emergence profile of just like an ovoid pontic. And the shape of the brandy snifter fits very nicely into that concept. So now that we have our crown, does it matter what sort of abutment that we have underneath there? That's the question that I want to ask. When we talk about the abutment shape and the tissue shape, and I'm primarily talking right now about the posterior area, we have different abutments from which we can choose. We have the standard abutment, we have the regular abutment, and what about a customized abutment? Well, I'll get to that in a second because I do have something to say about customized abutments. But with the ankylosing system, I'm just asking you to look at things from a different perspective. That's all I'm asking you to do because, as I said, all the ways of shaping the soft tissue are correct. This is just a little bit different. So we start off with our standard abutment. We start off with our regular abutment, if that's what we choose. And what about a customized abutment? Well, I had a graphic artist make up a custom abutment for me that goes down to the platform, which is different than a normal ankylosing type of abutment. But nonetheless, you see it's going to be like a conventional abutment with a margin a little bit more to the mesial and distal like what we're used to. And each one of these abutments is going to be able to support a crown. And the crown is going to be supporting the tissue. So the question is, does it matter what's underneath the crown if we're going to be supporting the tissue with the crown? So when we take a look at first the standard abutment, and you see the standard abutment and how it's going to be supporting the crown, take a look at the shape of the abutment and the shape of the crown. The shape of the crown is going to be forming the tissue. Now we'll just go ahead and morph that standard abutment into that of the regular abutment, and what happens to the crown shape? Nothing. The crown shape is exactly the same. So the shape of the tissue is going to be exactly the same. And what if we use that make-believe custom abutment that I just had the artist make up for me? The only thing that's changing is that at the apical end or at the gingival end of the crown, more of the abutment is going to be forming the tissue and less of the crown. A plus C equals T, but basically the shape of the tissue is going to be exactly the same. In fact, if you take a look at any type of situation that we have clinically, you could see that the shape of the tissue, while being perfected by that of the crown, really does not have to do much to do with the abutment underneath there. The shape of the tissue is going to be formed by the shape of the crown, and that's very important because we now have this emergence profile that the ovoid pontic that Paul Weigel and others have talked about. When we take a look at this situation over here, 3 standardized abutments, and you can see that the tissue shape was formed by the provisional restorations, not necessarily by that of the abutment. In fact, in one situation, I had the laboratory make up 3 different crowns on 3 different abutments for me, which they love because they know I'm only going to be complaining about one. But when you take a look at them, if I move all these different crowns around, you can't tell which one is which because the shape of the tissue is going to be shaped by the crown and not by the abutment underneath that. So it's an important concept to understand. Now, are there advantages of custom abutments? And yes, certainly they are. But let's take a look at some of those abutments, and again, primarily talking about the ankylosing system to see how we can circumvent that. The first one, to create parallelism in complex multi-unit cases. Well, very important, but as Maurice was talking about yesterday, the fact that we have abutments, we can choose to have them indexed if we want, or we can choose to go ahead and just have them rotate in any one of number 1 to 360 degrees or positions. For instance, this one over here, if we just want to rotate it 14 degrees, we could create that parallelism very easily with that. And what about all the other advantages? Again, in the case that you see on the left-hand side of the screen, we have a variety of different abutments. I could choose all the concepts that I want, whether to have a screw-retained bridges or cement bridges, whatever, and all these can be accomplished with a variety of the standard abutments or the stock abutments that they have. But there is one very important reason that we should use custom abutments. Anastasia was talking about that yesterday when she was talking about the cement problems that we have. So when we have custom abutments, we can then create an ideal finish line for the cement removal. But do we also need the custom abutments for that, or can that be accomplished with the stock abutments? And basically, as Nigel Sainer has been showing us he said he discovered this about 10 years ago, or he's been using this for about 10 years. Nigel's a lot bigger, so I'm not going to argue with him. But basically, what we do first is that we cement the crowns extraorally, wipe off the cement, and you can use this concept for any implant system that has got an analog. I'm showing it to you on the standard abutment system, but it can be used on any implant system that has got an analog. Again, wipe off the cement that's underneath there, and all the cement that's left inside that crown, that's all we're going to be needing to cement it onto the abutment, because the analog and the crown are the exact same things. But what if we have a customized abutment? No different. This article was written in the Journal of Prosthetic Dentistry by Pinheiro a couple of years ago, where we have a customized zirconia abutment, and we could follow the same concept. We take bite registration paste and we just squeeze it into the, we just squirt it into the crown. Very stiff bite registration paste. Remove it from the crown, and now we have our own analog. And again, we just go ahead and we cement it on that analog before we go ahead and cement it in the mouth. So the fact that we have certain very important reasons for having custom abutments can also be circumvented with the use of stock abutments. But what about the contours? The contours, the line defining the limit of something. How important are the contours for that of the crowns in order to go ahead and give us a proper contour of the soft tissue? Well, a couple of great articles that have been written about contours, one very recently by Dr. Sue and Gonzalez and the other by George Priest, and the one by Sue and Gonzalez Martin was written in the International Journal of Perio and Restorative just a couple of years ago, talking about the subcritical and the critical contours of the crowns in order for us to go ahead and shape the soft tissue. We know that the abutments are going to have a shape of the narrowness and concavity. But what about the shape of the crown? Because crown contour we've talked about in general terms being under-contoured or over-contoured, but from where does it start? Well, in that article by Sue and Gonzalez Martin, they said the critical contour of the crown really is at 1 millimeter below the tissue before that crown emerges from the soft tissue, and that is going to determine the zenith position of the gingiva, which means it's either going to be a little bit more apical or a little more coronal, or it can just ruin the whole case. So that 1 millimeter below the soft tissue is a critical contour that we have to go ahead and utilize. So sometimes we have a situation like this, and this was this oral surgeon's first foray into using ankylosing implants. He had a lot of excess tissue, and what we're taking a look at on tooth number 11, tooth number 2, 3 for our European colleagues, is a provisional crown that I made after second stage surgery with all this excess tissue. And the surgeon said to me, send the patient back, and then I will go ahead and either excise the tissue with a laser, a scalpel, or a diamond, whichever one you would prefer, and to get right to the appropriate contour so we can do our final restorations. And I didn't want him to do that because what if he took away a little bit too much tissue? So just to show you how important the contours of the crowns are, basically following the rules that we see in the literature, I removed that provisional restoration, and that 1 millimeter below the tissue, that critical area, all I did in this particular situation was add a little bit flowable resin to make it a little bit more convex, because now the convexity of that crown is going to push the tissue up a little bit more apically, or it's actually going to be shaping the tissue. And this is the result that we got after about 4 weeks, just shaping the tissue with reshaping the tissue with that of the contour of the crown, and we just let it stay like that until it's stable. In fact, when you take a look at the difference between what we started and what we wound up with, it's pretty incredible that this can be done with just changing the contour of the crown, and that's it. What sort of abutment was underneath there? It doesn't matter, but that was a provisional abutment. And again, we let it go. We let it get to this stable position. We go ahead and do our final impression. And in this particular situation, we used a zirconia abutment. But basically, the success of this particular case, although it be a single unit, was just changing the contour of the crown, and that was it. When we talk about the abutments and the aesthetics, or the light reflection of the soft tissue, which is the other aspect that I want to talk about, that David asked me to talk about, we know that there are various ways that we can go ahead and quantify the success between an aesthetic type of restoration or whether it's not going to be aesthetic. We have our white aesthetic score, we have the pink aesthetic score, we have the implant crown aesthetic index, a modified implant crown aesthetic index. We have our index of the California Dental Association, our 3 millimeter rule, and our 2 millimeter rules. All different ways in which we can go ahead and score whether we're going to be having a good result based upon using a titanium abutment or that of a zirconia abutment. And in an article that by Saylor that was published in European Journal of Aesthetic Dentistry 2007, it goes a little bit more into that as far as the determining factors for utilizing a zirconia or a titanium abutment. In fact, these are all the other criteria that need to go into that decision-making process. And basically, as I said in the article, that if we're going to be dealing with a very highly scalloped gingiva, a very thin type of biotype, where the person just wants the maximum amount of aesthetics, perhaps a zirconia abutment is going to be the abutment to use of choice. But is that always going to be the case? Is a zirconia abutment always going to give us a choice? Well, there's a law of nature, and this law of nature is two things cannot occupy the same space at the same time. Actually, this was given to me by Gary Brosel. Gary said he invented this little saying. I Googled it, and I saw Albert Einstein and some other people before him, some other Nobel laureates, but let's include Gary in the list as well, because he is a friend of mine. Well, this is what I'm saying. Two things cannot occupy the same space at the same time. It's either going to be the bat or the ball. Or in this case, it's going to be the guy's nose or the ball. And I could certainly relate to this because a few weeks ago, maybe about 4 weeks ago, I had a very similar situation, except it was with a brick wall instead of the ball, but my nose wound up pretty much in the same position. But what I want you to do is this. I just want you to focus on this titanium abutment and the zirconia abutment, because we can't always count on the zirconia abutments for giving us the best result. We'll come back to this in a second. There was an article written by Breslin on the influence of the abutment material on a gingival color, which was just published in the Clinical Oral Implant Research this past year. And basically, while they were saying in the article that no matter what type of abutment we use, there is always going to be a difference between the peri-implant mucosa around that abutment as opposed to that of a natural tooth. But when we do see the different change in color values, we are going to see probably a higher change with that of titanium. But is that always the situation? Coming back to this one over here, we have the zirconia abutment and the titanium abutment. But what you can't see is that this zirconia abutment is over-contoured. As a matter of fact, when you take a look at this zirconia abutment, which was an attempt by a laboratory to customize an abutment for me with the ankylosing system, you can see that the cervical aspect of that tooth, that abutment, is a lot wider than the tooth next to it. As a matter of fact, two things cannot occupy the same space at the same time. I want to have tissue there, and instead there's going to be abutment. When you take a look at this from a little bit more of an occlusal view, you can see from the titanium, that stock abutment, how much more tissue we have, that we can go ahead and shape that crown and be dependent upon that crown with a maximum amount of soft tissue, as opposed to having that abutment determining everything. Because while that abutment is very nice and very white and very aesthetic, based upon Furhauser's score and others, what happens now is that this abutment is a little bit wider, it's a little bit over-contoured. We're going to have a thinner layer of tissue around that, which is going to be more prone to recession. We may have started out with a thicker type of biotype, but now we have a thinner type of biotype. Now that abutment is going to be determining the crown, which is not what I want, because now the tissue is not going to have the proper contour, and it could be a failure. So in this particular situation, as you're seeing the one on the right-hand side with the titanium, that is going to give us the better aesthetic result, because we have more tissue with which we could work. We are not depending upon that. And the other thing is this. Having recession around a titanium abutment, now we're going to be going ahead and seeing the junction between that, between the zirconia abutment and the crown. Now we're going to be seeing that junction. So as I say in the article, perhaps the contour of the abutment, just because it's a white zirconia abutment, the benefits may be controversial. Well, we also have the 3mm rule, Ronald Young's classic 3mm rule. And when you see on Dental XP how David interviewed Ronald Young and he said this is a classic article, he's exactly correct. Because this was the first article that really showed us that beyond 3mm of tissue thickness, the eye cannot really discern what we're seeing behind that tissue thickness. So you can put anything behind there and you're not really going to have any sort of advantage of that. But the question that we have is, where is this 3mm located? Where in an apical incisal direction is this 3mm going to be located? Well, when we talk about that, there was an article that was written in a clinical oral implant research by Von Rankel and others, talking about the distance from the gingival margin in increments of 0.2 millimeters. And this is one of the few articles that has really gone to the extent of measuring the thickness of the layer of the tissue from the incisal aspect down to the fixture level or the platform of the implant every 0.2 millimeters, because we have to see where this 3 millimeters is. It's nice to talk about it when we're looking at it from an occlusal direction, but where in reality is that? Well, it was interesting because at 0.2 millimeters, we only have a millimeter of thickness. At 1 millimeter, we only have 2 millimeters of thickness. And why is this important? This is important because people who like using custom abutments, when they say that they like having the scalloping of that custom abutment following the parabolic curvature of the soft tissue, they like to have this at 1 millimeter. But at 1 millimeter, we're still going to be able to see a show-through of whatever we have. As a matter of fact, it's not until 2.2 millimeters that we start seeing the majority of the people in this study that's had that 3 millimeters of thickness. Well, one of the things that we're very fortunate about in using this implant system is, as I said earlier, we are not dependent upon the platform for anything. So two things cannot occupy the same space at the same time. What I would rather have is a soft tissue filling in this area than a titanium or zirconia or anything that is non-soft tissue. So we have to take a look at it from that aspect. In one situation in our office very recently, I had 3 different types of abutments made for the same patient. In fact, when you take a look at the 2 different types of titanium and the zirconia abutment, you're absolutely not seeing any difference in the soft tissue because of that built-in thickness of the soft tissue that we get with the customization of the abutment, of that narrowness and the concavity. 3 different types of crowns. And again, you're not seeing any sort of difference because of the thickness of the soft tissue that is there. As a matter of fact, Dr. Colucci, who's going to be speaking later on, and I made sure that I'm quoting this correctly when I saw him last night because I didn't realize he was going to be speaking here, but as he says, the material chosen for fabricating an implant crown per se does not ensure an optimal aesthetic outcome if other aesthetic parameters are not present. Tooth number 7, where we had this implant problem, it doesn't matter what sort of abutment we have or what sort of crown we have, because if we don't have any of those other factors that are on the other side of the screen, with the tooth morphology going down to the tissue aspect, we're not going to have any aesthetic result regardless of what type of implant system we use. On the other hand, when we do have everything going for us, we can get 4 implants next to each other with a very nice aesthetic result, all on titanium implants, but because we have all the soft tissue going with us, because we're also maximizing the amount of soft tissue. So I'd like to finish up just combining everything and talking about the surgical and the prosthetic advantage. This was given to me by Dr. Alan Fentner, periodontist out of Jacksonville, Florida, showing how he uses this system to its maximum with regards to the prosthetics as well as to the surgical. Alan likes using stock abutments for his referring doctors because for cost factor and other ways. And it doesn't matter if it's titanium or zirconia, but he does like using the stock abutments. And what he does is every time at every surgery, what he will do is after he places the implant, he puts on that stock abutment to see where it is in regard to the margin. And in this situation over here, even though this is a balanced anterior titanium abutment, again, with Nigel always calls his very favorite sexy type of abutment, which I still don't get, but it is a beautiful abutment. Alan sees that in this particular situation, while he wants to go ahead and use this, he realizes that from the incisal aspect and from the lingual aspect, it's not going to be enough clearance, just like with the natural tooth. So he knows in this situation that he's going to have to go ahead, or the dentist, the referring dentist, is going to have to take this and send it to the laboratory for customization. But what he does is he takes advantage of the system that we're talking about. And what he does is he places the implant a little bit deeper, which we can, and as Dr. Adriano Piatelli is going to be talking about later on, in fact, he just had a very great article that was just written in J. Peri about the subcrestal placement. Alan, taking advantage of that, places the implant a little bit deeper. The abutment is going to be a little bit deeper, and now he knows that he can hide that tissue because of the thickness of the tissue that we have within here, and now we're into our minimal connection disconnection technique, because we can't always do one abutment one time. So he's taking full advantage of that. There was a book that was just written, the Peri Implant on immediate loading by Dr. Testori, and he has one chapter in there that talks about the Peri Implant biologic space. And with permission from Dr. Testori, I scanned this image in because it was a very telling image. And what he was talking about in this image is that when we have enough bone, when we have enough soft tissue, we have the world at our disposal. We can use any sort of anatomic abutment with a wide horizontal margin like what you're seeing here, any sort of crown, and everything is just great. But what happens, as he states in this article, and this is where I kind of modified his image, if now we have a little bit less bone, a little bit less soft tissue? Or what happens if the implant is going to be placed a little bit more to the labial, and now we have a little bit of an angulation, so we have the trifecta of poor placement at this point? We know that at this point, if the implant is going to be a little bit angled, that we now have that prominence of where the soft tissue is right at the junction of the crown and the abutment. And we know that this area is going to be prone to recession. So what he said is that perhaps we need to think of a custom abutment, but a different sort of custom abutment. We need to think of an abutment that is a shoulderless type of preparation on the abutment, that we don't have to have the crown going all the way down to that margin, so that he's maintaining the thickness of the soft tissue, and the crown, because there is no margin, can be cemented a little bit at a little bit of more coronal level, but now we still have the soft tissue and the crown maintaining, the abutment and the crown maintaining that soft tissue. It's just as he says in his textbook, we just have to take a look at this from a different perspective. Well, when I was looking at this abutment in his text, I'm thinking about it, this is exactly what we have at our disposal with that standard abutment, with the exception of one advantage that we have, because we also have that narrowness and that concavity where we can get an increased amount of tissue thickness. And this whole thing comes together when we learn about this. In fact, a lot of the things that we learn really turn out to be from our more simplest type of situations. This is a situation where I'm now combining everything: the shape of the tissue, the color of the soft tissue, the surgical prosthetic advantage of the abutments, and everything else. Tooth number 23 has to be extracted. Tooth number 32 for our European colleagues because of internal resorption. And all I said is to the periodontist with whom I was working, and he hates when I show this because well, whatever. The last thing I said to him was make sure, because we were going to be doing an immediate provisionalization on this, and I said, obviously, just use a 3.5 millimeter implant. And of course, well, as with the case many times, people just don't listen, okay? And I'm not saying, and Bill did a great job, but he also knew that he was able to take advantage of this situation. Because even though we have a wider abutment, a wider implant in this situation, if we were dealing with a system that the platform of that implant was going to be dependent upon making that crown, we would have been in trouble. But because we have the advantage of having this independent of the implant system, we now can have a very physiologic type of provisional crown. And look where that bone is on top of the platform. And this is at day 0. Because he knew that with this system, we have different types of implants. We have a 3.5, we have a 4.5, and we have a 5.5 millimeter size of implant. But to us, in a restorative world, the only thing that we care about is a 2.5 millimeter opening. Because regardless of the type of implant that he's going to be placing, that 3.5 millimeter implant is going to be able to accommodate that abutment, as well as the 4.5, as well as the 5.5. Our micro gap is being moved medially. We have no micro gap, there is no micro movement, and everything else that we know about the system is going to work to our advantage. And we saw this patient for our normal protocol, following her for the first month, and then did not see her until 3 months later when we were going to do our final restoration. And when you take a look at the provisional restoration, this is when we really saw the beauty of the system. You take a look at that provisional restoration about tooth number 23, and you see the tissue looks just about perfect, insofar as color, insofar as shape. As a matter of fact, what you're taking a look at now is the first time that I went ahead and removed that provisional restoration, and look at that thickness of the tissue. I truly believe that with any other implant system, we would have been stuck in this situation because we would not have had that maximization of the soft tissue of thickness. When we take a look at the final restoration, and then we take a look at a post-op radiograph at about 1.5 years later, there again, you see the bone on top of the platform. That bone is going to, so you support the bone, you're going to be supporting the soft tissue. Any other system, we would have been dependent upon the platform, we would have lost all that bone, again, not just mesially and distally, but 360 degrees around. So, to sum it up, sometimes while we have a choice between an anatomic abutment and maybe a non-anatomic abutment, sometimes we have a choice of we just use a non-anatomic abutment to get the better sort of result. A plus C equals T, with the exception of one thing. We have to include the V. And the V, just all the variables. So we have our abutment, we have our crown, we have all the variables. That's going to equal the tissue thickness, the proper tissue. And I'd like to sum it up by saying this: we are what we repeatedly do. Excellence, then, is not an act, but a habit. And I believe everybody in this room follows that habit. And I want to thank you very much for allowing me to speak to you here. Thank you.